Pamela, I think we have 15 minutes till, or 10 minutes till 20 past for us to resume your panel if we're to stay on schedule. And I hope that wasn't too disruptive. But I think, again, it was very important for us to hear that message. So, Pamela, back to you.
So we had this gentleman who patiently waited.
Hi, thanks. Mark Goravich from the Department of Population Health at NYU School of Medicine. Question about the, it's really about the time horizon and the practical utility for policymakers of some of what you presented around Rethink Health's model. There was on the video a user interface that showed all the buttons one could move to the left and to the right. How over a long period of time, the impact of any one of those, let alone many combinations of them, obviously it gets harder to predict in aggregate. And so I'm wondering, when you work with Pueblo, Colorado, or other cities, how practically have you applied this, and how has it affected decision-making in real time?
Yeah, it's a great question because there are two things that go on when you look out into the future. One is we have this intuitive sense that the world is very complicated and you can't anticipate surprise, and there's all kinds of sort of outside events that could really alter the course of the future. And this may sound like a semantic point, but it really matters. Is we're not trying to predict some point into the future. We're not trying to estimate what the health of the population will be 25 years in the future, what healthcare costs would be. What we're doing is trying to sort of play out the consequences of actions taken now and see, how long and how strong those efforts, can be, what the general trajectory of those things are. So it's really more of a policy evaluation tool than it is a forecasting device. So that's the first point, and which is one of the reasons why we never show single curves out into the future. I mean, we have a baseline that is sort of a status quo, but the purpose for building the model is to ask, if we, within our latitude of influence, can change present circumstances, how would that scenario look different? And so we're really looking for pattern. The timing, magnitude, and shape of those curves is really what the inquiry is about. That sort of raises the question of are there inherent processes, let's say with chronic disease, for the incidence leading to mild forms of disease that over time will turn into more severe forms of disease, without getting into fancy assumptions of the future, just saying what the sort of progression of a process that has inherent time delays will be, helps us understand the urgency or the stakes involved of taking action on it at the moment. So in this way, the models are imperfect because we're not trying to anticipate new technologies, let's say, or new social trends and movements. That's like beyond what we're doing. It's much more humble. Is how well do we understand how well honed are our intuitions about the kinds of consequences of actions taken in the present? That's really what the tools do. And just a word about how users experience this. And there are some in the room. I'm looking at Karen Minyard, who leads a group in Atlanta, who have really made an explicit point about the value of a 25-year time horizon. That choices and constraints that people are facing now are linked to decisions made decades ago in terms of how much to invest in a tertiary care disease-focused system, and how and how many questions we have about what can make a difference in population health, or how we've allowed evidence to accumulate without actually taking action on it. So these choices, that present leaders are facing are rooted in sort of historical choices, and the choices they make now are going to play out for another couple decades. So you're thinking over really quite a long period of time, but the commitment is for present action, and my understanding is that that's a pretty valuable perspective for leaders to have. Well, anyway, we'll say more about that, and Karen can say more when she speaks later this afternoon.
Hi, good morning. I'm Laura Sneebold for NACHO, or the National Association of County and City Health Officials. And my question is in regards to data. So from the local perspective, we know that local health departments in particular use data and collect and translate it to improve the health of the community and the local public health system. but we know that there really are very real challenges around timeliness of data and also availability at the local level. So can you speak a little bit about your experience either in experiencing those challenges or successes in garnering data to support models at the community level from a systems perspective? And
Start, and maybe others will have more to say from their work.
Oh,
go
okay,
ahead.
and I have one more.
Okay.
My second question is, from your perspective, given the trajectory of modeling as it applies to improving our health and our health system and informing policies, do you see a call for more attention to this challenge in data availability at the local level? And also, where do you see the role for either the field of public health informatics or other entities that are really involved in the collection and then exchange of data from different sectors as we think about more the kind of the total population health approach?
Yeah. This was a very conscious question as we began constructing the Rethink Health model. To what extent can we gather enough data, enough of the right kinds of data to create a credible portrait of a regional health system? And that was a feasibility question as we began this work. And our sort of discipline of building models is really intertwined with how we represent the phenomenon. It depends on what information we have to justify those claims. It is a hypothesis of the phenomenon that we're trying to study, and we don't just speculate about that. Everything that ends up in the model has to be linked to some kind of evidence. On the other hand, and it is the case that there is quite a bit of information in the sort of data landscape. There's even more that people understand about their experiences that hasn't been formally documented but can actually provide real valuable experience about how these systems tend to work and how they've been changing over time. So the model as a sort of object can be a way of mapping data from very different sources into a sort of common framework. And just like a GIS map brings data from different places onto a frame, this is more of a conceptual representation of the moving forces of a system. But the Rethink Health model, for example, brings dozens of data sets together and different literatures that speak to different parts of the system, so that you're not relying on one data set or one literature to carry the whole data question. One other comment about this is that while we try to get all the information we would want at the lowest level that the model represents, often that's not the case. So we look to data sets of state and national sources and often do sort of demographic adjustments to begin to fill gaps that you simply don't have at the local level. Those two can be subject to uncertainty analysis and all the rest, but we have quite a rich data environment in the health arena, and it doesn't make for perfect models, but it does make for well-informed ones. And I see the demand for better data, and particularly longitudinal data. Like there's a lot of cross-sectional data done once, or things occasionally disaggregated by race, ethnicity, age, but then the next year it isn't. And so you end up with this patchy picture of trends. And so I hope that the more we do modeling, the more people get, create the norms for time series data disaggregated the way we really need it to for policy purposes. And
Bobby, I think if I understand right, you sometimes put in data from the community.
We would never start without some local foundation, knowing the geography, the population composition, health status of the people. Then it comes to other data elements that simply are not available locally, but often like California does a much enhanced California Health Interview Survey, different than behavioral risk factor surveillance system, and those data prove very valuable in representing cities in California, for example. So we're not above getting information and using it to shed light on a region that would be nested within that framework. Now, there's lots of checks on that. If the region is systematically different than the state averages for one reason or another, we can confront that and address it, and often deal with it consciously as we interpret the results. I will say, though, that the lack of data is not an excuse to not model, right? I mean, often you don't have all the information you want, and the modeling surfaces what we need to know, what ought to be better measured, how precisely. We're not really equipped to have that conversation about what our information landscape ought to look like without some kind of modeling, mental or otherwise.
And the community health advisor model it's there as a model, but then it's county level data. It's pre-populated with the county level data, so you could then run the model on that county's baseline data. So I think there are probably millions of examples like that.
Thank you.
Good morning, Jeff Levy, Trust for America's Health, and a member of the Roundtable. So I'd like to talk about another data gap, and I think and sort of in a more perfect world, I'm assuming that there are limits to the data about the value and the effectiveness and the cost and all these other things of the interventions that you are modeling. And in my very limited experience in working with modelers on some of this, it's stunning sometimes what kind of data we all would like to know that NIH or CDC-funded studies aren't collecting. And I think we also have a time frame issue where most of these studies are very short term. So I guess my question to you is, in a more perfect world, what sort of standardized information about interventions would you like, at least federally funded and philanthropic funded, since we at least have those two parties here, research around the interventions would collect so that your models could be more robust? I won't say more or less accurate.
So, goodness, one of the important gaps in data that we are looking in tobacco control right now is that we see that there's a departure of behavior in tobacco use from what is implied by these big macro models that are informed by large data sets, survey data like NHIS and BARFAS. So what we are looking now is that the interaction of people and how people transmit the smoking behavior, how people communicate their intent of quitting or engage in the smoking behavior is important. So these interactions, these social networks are becoming more and more important in order to study at least this area of tobacco control. So we are looking at a landscape that is much more heterogeneous right now and is much more complex, and in which those social interactions and these interactions, those ways in which people relate to each other, influence each other, are becoming more different. And that's the type of data that is not reasonably well collected, and that's something that we have used individual-based models to generate hypotheses about what would be the impact of this interaction, but we don't have a good set of data that will inform how these interactions are going to play out, for example.
I mean, I guess my short answer is almost every part of the modeling process can be better informed. And so there's the description of phenomenon and processes that matter, ends up affecting the theories that people model. And so there's quite a bit in that arena. When it comes to representing initiatives that, what if scenarios, the implementation cost would be sort of high on my list of what was actually invested to achieve the change that people, were purporting to do, and the extent to which that was implemented, and sort of issues of dose. Our colleagues at Kaiser have done some of the best work around, about how strong was the effort and what fraction of the population did it reach. These things multiply together, and you can end up with a modest intervention reaching 20% of the people, and you end up with 0.5% dose, when really our theory said that we were going to have a massive initiative affecting everybody. So these multipliers, which again, when you're dealing with simultaneous processes, that's what the modelers will bring to the decision makers, saying, well, I hear you telling me you're going to start small and it's not going to reach everybody. What kind of impact are we expecting to have here? I think knowing more about the reach, the effect sizes, and the costs associated with mounting those things would make a huge difference.
We can take one more question and a succinct response.
Bob Grist with the Institute of Social Medicine and Community Health. One gap that has not gotten any attention so far is the lack of data on political constraints on the interventions which are possible at the community level. We all have our favorite examples of communities that have changed. My favorite is Rochester, New York, during a certain period of time. I'm wondering how modeling can begin to incorporate political factors which influence the kinds of interventions that are considered politically realistic. Because in the absence of that kind of information, I'm not sure we're going to get the kind of political accountability that we would need to change the system in ways that would promote public health.
No better case example. So my first thought is, again, I think it's fair to say that we all have different approaches to how we do modeling. So using my approach, I always think in terms of rows and columns. I'm useless unless I have rows and columns. So my first instinct would be to press U for, it's unstructured information, right? It's nothing that we measure. It's political influence. It's political interplay. I would prompt you for the question, is there a way of coding that so that I can represent that in a row or column? And that would be my first instinct, I guess, as a modeler, is to try to take that unstructured information and structure it. That will allow me to capture it in the model.
David, do you have a last word for us?
Yeah, there is, I think, to my way of thinking about this, there's no really a formal way to incorporate this, potential feedback that can, influence the decision through, some political agenda. But we can make models that make them explicit, so we can anticipate, we can actually be aware of their potential consequences. So when we look at the landscape of the modeling that we are doing in order to put forward a policy, let's say removing menthol from the population, reducing levels of nicotine and tobacco. So the modelers, will start by doing a direct model of the health consequences, the impact, but then after that, then there is a second layer of modelers that will think about what will be the reaction from the public. What is the potential reaction from the tobacco industry? What is the challenges in courts, for example, that the tobacco industry might pose to models like that? So we are aware in not some of quantitative model, but in some sort of mental or conceptual models of the things that can prevent a completion of the policy. But, and we can do some sensitivity analysis around what would be the potential impact or delays of those policies, and probably avoid certain pitfalls in doing that.
Thank you.
Excuse me. Could I add one comment to that question, please? Very quickly. I'm Patrice Pasquale from the Children's Dental Health Project. We just did our first model actually with your colleague, Gary Hirsch, to look at how you could reduce cavities among early children, because when you get children early in childhood, you can stop the whole progression of cavities. So what we did is we came up with the model, and it had its implications. For instance, things like increased toothbrushing or community water fluoridation. But then going to the point which we've heard earlier, you take the model results to the community and you do the feasibility testing with the community. So they look at the political ramifications and they look at the pathways to deciding which of these interventions, now that they have some data, they can get behind and push. So I think it just speaks to even what we heard from Dr. Zhao, you take the results and you really then have a whole pathway for bringing them to the community.